Hello, welcome to our webinar. Thank you everyone for joining us today. My name is Jenny. I'm a part of the education team at Medit. Nice to meet you everyone. And today we have Dr. Mohammed El Ashri. Hello, how are you, doctor?
Hello everyone. Hello Jenny.
How are you?
Fine, thank you. How are you? All good?
Yeah, everything all good. Thank you for asking. So you
Thank
seem
you. Thank you.
very busy.
Yeah, slightly trying to make a lot of things together, lecturing at university, studying also, so slightly busy. Yeah.
Yeah, I can see your face much smaller because you're
Yeah.
busy.
Thank you very much for the invitation, Jenny, for this webinar. I think this is the third one together.
Yeah,
Discussing the five, if you remember, the five main concerns regarding the digital dentistry and how to enhance precision. So I think today's topic is one of the most important topic and one of the hugely underrated topic in the practice of prosthodontics, which
yeah.
is occlusion. So let's start.
Okay. Let's get started.
So, thank you, Jenny, very much for this invitation for this webinar. And I'm going to discuss today digital occlusion or occlusion recording for complete mouth rehabilitation cases and also for aesthetic rehabilitation cases, especially with implants. So, just a reminder of what we have discussed before, which are the five concerns to achieve the required precision for the digital protocol or the digital workflow, which were PEP criteria and tissue management, ideal data, and how to capture the ideal data, and the difference between the enough data and the ideal data. Models, are we still needed models or not in the digital protocol? And finally, the occlusion. We already discussed in the last webinar the PEP criteria and also the tissue management and how to achieve hemostasis before scanning, and also how to capture the ideal data required for very nice seated prosthesis without any interferences along the path of insertion, or also without any interferences to the scanning or the scanning protocol. And today I'm going to discuss the occlusion, because occlusion can be a detrimental trigger for prosthetic failure and also for implant failure. And occlusion is one of the hugely underrated topic in the practice of prosthodontics. So usually our role as a prosthodontist is to restore with precision, to restore the ideal occlusion, and also to restore and duplicate the patient functional movement to a very good level without any interferences or without affecting the patient border movement or the functional movement of the patient. And usually this precision is related to how to make your impression or the impression making techniques, either doing the impression with digital protocol or doing the impression with your conventional protocol. And because we all know, as I discussed before, that the traditional impression was the reference standard for complete mouth rehabilitation cases for long decades with elastomeric body wash impressions. But we have a lot of problems regarding the dimension and stability of these impression materials, and also the technical errors that might affect the ideal capturing of the details of the finish line and also the walls of your preps, and also a lot of problems regarding the dimensional stability of the stone products or the boring process, and also a lot of problems and technical errors regarding the boring process, which will or might affect the quality of interocclusal registration and also for mounting techniques regarding full mouth cases. And because most of the bite registration materials have a lot of errors, sometimes we have a very soft bite registration material, sometimes we have too deep indentation, so the cast is not seated properly to record the protrusive or the lateral movement, like in this case. Here we have a very deep indentation, so the soft tissue can press this silicone material, but the cast cannot, so we have a problem regarding the ideal interocclusal registration. Sometimes we have very shallow bite registration material, so the cast is not properly seated. Or we can use a digital impression, which is proven nowadays to be very nice, or with the same accuracy or even superior accuracy than the traditional elastomeric impressions. But we have a lot of errors also regarding the digital protocol. But the most important thing regarding the interocclusal registration is that we must have a minimum errors for around 50 micron or less than 50 micron. So if we have a lot of errors regarding the digital dentistry, because we have three types of error regarding the trueness of the scanners, also from moving the data from the scanner to the CAD softwares and also in the CAM softwares, and all of these errors will affect the quality of the interocclusal registration. So the only number that can be modified is the IOS trueness, which should be minimal to decrease this huge number of errors to enhance the quality of the interocclusal registration. So what is better now, to use an interocclusal record with elastomeric compression or to scan the interocclusal relationship with your scanner? Actually, according to literature, we have minimum error when using digital scan with less than 50 micron, which is very nice to achieve a proper interocclusal registration. So today I will try to discuss how to integrate the softwares, especially Medit softwares, to enhance the ideal occlusion outcome for aesthetic and complete mouth rehabilitation cases. And because usually our rule as prosthodontists to in digital aesthetics especially is to restore the ideal function and the aesthetics and also the occlusion. And we have three primary requirements for any successful treatment according to Peter Doss. The first one is we must have a very stable TMJ without pain, without discomfort, without clicking, without any sound regarding the TMJs. We must have anterior teeth in complete harmony with the envelope function without any interferences that might affect the TMJ or place a kind of overload on the disc or on the TMJ. And finally, we should have non-interfering posterior teeth regarding the protrusive and the lateral movement. So sometimes we have a lot of aesthetic challenges, not only the shape, the contour of the teeth, the gingival inflammation, but sometimes we have a lot of problems regarding the excursive interferences. For example, for this case, this is a protrusive movement, we have canine interferences. This canine will affect the occlusal relationship and also will affect the quality of the TMJ. And this patient came to my office seeking treatment for these restorations and also complaining from a severe pain in the TMJs. For the lateral movement, we have two central interferences and we have very large amount of this occlusion on the opposite side. Actually, according to Hobo, we should have around 1 to 1.5 millimeter of this occlusion at the working side and non-working side. Look to this photo, we have a very large amount of this occlusion, more than 3 millimeters, so we are placing heavy forces and severe loads on the TMJ leading to pain and discomfort. And the same for the opposite side, it's canine guided, okay, but we have a lot of interferences regarding the two centrals with large amount of this occlusion in the opposite side, which is the non-working side. So one of the primary requirement for this treatment is to achieve a proper occlusion without any interferences in protrusive and lateral movement. So usually my protocol is to start a proper diagnosis for such cases to be able to reach to the ideal outcome. So using the scanner and jaw motion softwares from Medit, we can here also analyze the patient movement, protrusive and lateral movement. So we can see a lot of interferences regarding the protrusive movement and also the lateral movement. This movement and this recording can enhance the outcome because we can make a proper analysis for this patient border movement. and also confirmed by the videos for the patient movement, protrusive movement with interferences at the canine, and also the lateral movement with interferences at the two centrals. So we have a problem regarding the TMJ. We have vein. The patient have a lot of interferences regarding the anterior teeth and also the posterior teeth. Yes, we have non-interfering posterior teeth, but with large amount of this occlusion leading to failure. So in order to enhance the guidance or the anterior guidance of this patient, we have to adjust the anterior guidance according to the patient border movement. So a very nice outcome can be reached with scanning the patient border movement to fabricate the restoration according to both the condylar border movement and also the anterior teeth position to achieve the ideal or to reach to the ideal anterior guidance. So according to the new protocols, we are not doing 2D smile design anymore. We're not doing 3D smile design anymore. We are doing a 4D smile design based on the patient border movement. To adjust the four elements of the anterior guidance, which is the contact or centric contacts, horizontal position of the incisor guidance, and then the vertical position, and finally the guidance contour. So after you take the scan for these cases, we can do virtual mounting according to the techniques that I will discuss by the end of the presentation to adjust these four elements. Now we can adjust the protrusive movement without any interferences at the canine and also the lateral movement without any interferences at the centrals or the laterals. So this is the final outcome. We have a very nice aesthetics, okay, but also we have a very nice occlusion with protrusive movement, and here's a video for the protrusive movement. And thanks to the GeoMotion software, we can record the patient movement to also make better analysis for any interferences to avoid any failure or any interferences in eccentric or protrusive or lateral movement. So here a protrusive movement without any interferences. Here you can see the patient is sliding on his anterior teeth with complete disocclusion of the posterior teeth. And the same for the lateral movement. Here we can see the lateral movement and also confirm it with the lateral with GeoMotion software. Here's the canine guidance, and the same for the opposite side, canine guided with no interferences at all. So we achieved the ideal outcome that we want to have. We have a good aesthetics, we have a very nice function, and also we have a very accurate anterior guidance. And also for implants is very important to take care of the occlusion scheme regarding implants because we should decrease the amount of forces and we have to adjust the occlusal scheme in centric and the eccentric forces to avoid heavy occlusal contacts on implants crowns. So a very nice criteria for the GeoMotion also software is to and also for the occlusal analysis is to record and to analyze that we have a minimal centric context to accommodate the movement of the teeth within the elasticity of the PDL without placing heavy forces on the implant crowns. So we can confirm actually with the conventional protocol, and also we can confirm the low forces or minimal forces on the implant crown with many digital protocols. One of them is the occlusal analysis software from Medit, and the other one that I'm using is the OccluSense, which is a digital sensor that can quantify the amount of forces on each tooth. So for example, for this case, we had placed implant in this canine, and after scanning for the occlusal analysis, we discovered that we have premature forces on the left canine. So these premature forces prevent the complete closure of the posterior teeth. So we have a very high bar of forces on the anterior teeth, which is the canine, and very low bar of forces on the posterior teeth. So we have a lot of interferences which might affect the integration of this implant and might lead to failure of the implants. So it's also confirmed with OccluSense. Here we can see a very high bar of forces at the canine, and with little occlusion of the posterior teeth. So after adjustments, we have a proper occlusion of the posterior teeth, which is mutually protected occlusion. So we can decrease the failure of this implant crown by making a very small and easy steps, which is occlusal analysis. Also, for the eccentric context, we have to remove any eccentric interferences in the protrusive movement according to the patient movement. So for this implant crown of this lateral, we have to remove any eccentric interferences, and also can be confirmed with the jaw motion software, so we can make the patient protrude at the protrusive position. And now we can scan this relationship to make sure that we haven't any interferences along the protrusive path of this patient movement, to avoid any overloading on this crown, because this overloading might place a lot of forces at the crestal bone, leading to further bone loss. And now I'm going to discuss one of the very important situation, which is complete mouth rehabilitations, and how to enhance the interocclusal restoration for complete mouth rehabilitation cases. And I will try to answer the most frequently asked question: how to record the vertical dimension and the centric relation of complete mouth rehabilitation with complete set of teeth with dentate patient, or even with non-edentulous or edentulous patients, especially for implant prosthetics or implant cases. So the concept of complete mouth rehabilitation depends on three main principles. The first one is the existence of physiologic rest position to be able to record the ideal vertical dimension of occlusion, which is the difference between the vertical dimension of occlusion and vertical dimension at rest, and then to restore and to duplicate even the dynamic and functional patient occlusion, and also to restore the centric relation or even the centric occlusion. So usually for any case with complete mouth rehabilitation, we should have a customized scheme starting from proper diagnosis, then a smile and functional analysis, and then restore the vertical dimension of occlusion and centric relation, which is the topic of today's webinar, and then how to make a feasible transfer, virtual feasible transfer and mounting, and finally the design of the final prosthetics. So today I'm going to discuss the third and the fourth step, which is restoring vertical dimension, and then how to mount the relationship using feasible transfer, digital feasible transfer, and how to mount this orientation on a semi-adjustable articulator. So the first one, which is how to restore the vertical dimension and centric relation. Actually, many cases of complex full mouth rehabilitation cases may consider raising or altering the vertical dimension of occlusion. So this step is very crucial and very important. A very short notice about the vertical dimension. Vertical dimension is the distance between one fixed part and one mobile part. The fixed part, which is the tip of the nose, and the mobile one, which is the chin. So the vertical dimension of occlusion is this distance, but when the teeth are occluding together. And we all know that we have three facial heights that should be equal in many of the cases regarding the vertical dimension of occlusion. And we must have a minimum of 2 mm of interocclusal rest space or freeway space to be able to raise the vertical dimension of occlusion. Of occlusion is this distance, but when the teeth are occluding together. And we all know that we have three facial heights that should be equal in many of the cases regarding the vertical dimension of occlusion. And we must have a minimum of 2 mm of interocclusal rest space or freeway space to be able to raise the vertical dimension of occlusion. If we have less than 2 mm, we have to use another technique to restore the patient short teeth, or also to make complete mouth rehabilitation, like ortho intrusion or surgical crown lengthening. So a very important thing is to record the interocclusal rest space to be able to record the vertical dimension of occlusion, which is the difference between the vertical dimension of occlusion and vertical dimension at rest. This interocclusal rest space should not be less than 2 millimeters. And also, in order to record the vertical dimension of occlusion, we must record this relationship in what we call the stable musculoskeletal position of the condyle, which is the anterior superior position of the condyle, which is the centric relation. So when recording the vertical dimension in complete mouth rehabilitation cases, centric relation should be also recorded to achieve the ideal relationship between the condyle to the articular surfaces. So how to record vertical dimension and centric relation in the two main situations, with dentate patients and also with completely edentulous patients for implant prosthetics. Usually, if you want to record the vertical dimension, raise the vertical dimension with dentate patient, we can use a kind of anterior deprogrammer or anterior bite stopper. This anterior bite stopper will separate the teeth according to the new vertical dimension, and then you can deprogram the mandible with any technique according to bimanual manipulation method by Peter Dawson to seat the condyle in the anterior superior position. Now, with the old protocol, with the elastomeric impression, we can record this relationship with any elastomeric bite restoration material. But nowadays, we can use this scanner to record this interocclusal relationship. So we can use any kind of anterior deprogrammer or any type and any method of centric relation recording to record this relationship by manual manipulation, lossy jig, anterior deprogrammer, leaf gauge, or even Gothic arch tracer. So for this case, for example, for a single arch, this patient have collapsed vertical dimension due to loss of posterior teeth support. So according to the face scan, we have diminished lower facial height to be more than this to be equal to the middle third and the upper facial height. So for this situation, we have to raise the vertical dimension and also to have enough space to restore the posterior teeth. So after taking the scan, we can place this anterior deprogrammer, which is leaf gauge. With leaf gauge, we can raise the vertical dimension, and also we can deprogram the mandible to the anterior superior position, which is a centric relation. But now, can we place this kind of leaf gauge and then we can make the scan right and left according to the relationship? Actually, when placing the leaf gauge, if you try to take the scan, the mandible can slide right and left, so your relationship is not accurate at all. So my recommendation, usually after you deprogram the mandible, you can place composite jig just to maintain the ideal vertical and the ideal centric relation, and then you can scan the relationship. And also my recommendation, according to my experience, to scan the relationship in one shot, right and left together. Because according to literature, if you scan the right alone and the left alone, we might have a kind of tilting effect towards the registration site. So it's better usually to scan it in one shot to avoid any tilting towards the interocclusion registration site. So this is the final scan. But do you think that the intraoral scanner can record this space in a very accurate way? Actually, according to literature, the trueness of the intraoral scanner increased when there is space between the upper and lower arches. So no worries at all about the amount of interocclusal distance between the upper and lower arch when recording completely dentate patients with centric relation and with vertical dimension. So we have to make BMA try-in with very nice aesthetics, very nice occlusion, and very nice also vertical dimension of occlusion. And if you remember the 1 to 3 rule, that raising 1 millimeter posteriorly will raise 2 millimeter anteriorly and 3 millimeter at the incisal bin. So in this patient, we have almost very nice equal 3/3 of the facial height. So in this patient, we raised around 1.5 at the anterior teeth with the leaf gauge, which lead to 0.7 millimeter at the posterior teeth and around 2.5 millimeter at the incisal bin, which is the distance between the nose and the chin, which is accurately confirmed with the face scans. So moving to the next protocol and the next strategy, which is how to scan two dentate patients or two dentate arches when we have a severe loss of vertical dimension, like in this patient with severe wear. Actually, in this case, we have to raise the vertical dimension to have a proper interocclusal distance to restore the upper arch and the lower arch. So proper diagnosis here is very meticulous and very important to be able to record the ideal amount of vertical dimension of occlusion. So we can use the Medit plan software to fabricate a kind of Lucia jig with different thicknesses, and we can select the ideal thickness according to the needed raise of vertical dimension. So this is a Lucia jig with flat surface to deprogram the mandible in the same vertical dimension in the ideal centric relation. So after printing this guide, after printing this plant, here is the final scan after deprogram the patient with the same protocol as I discussed before. Here is the vertical dimension in the ideal centric relation. Now we can make mounting according to the technique that I will discuss later on. And here is the preoperative model and the model with WAXAB or virtual WAXAB. So how to transfer this WAXAB to the intraoral situation. Actually, I use this very nice material which is transparent polyvinyl siloxane. I think it's Exacclear, so I can inject tooth by tooth. Now I can transform the virtual mockup into an intraoral bonded mockup. Now we can make reduction tooth by tooth with fabrication of provisionals, and after you finish, you can remove the anterior provisionals, keeping the posterior teeth in contact to maintain the vertical and centric relation. Now we can place composite jig and the anterior teeth, and now you can remove the posterior provisionals to scan the relationship. Now you have the ideal recorded vertical dimension and the ideal maintained centric relation, which is accurately produced by this composite jig. So this is the final scan with a very nice interocclusal distance and many cases with the same protocol, removing the anterior teeth, placing composite jig or any kind of deprogrammer to deprogram the mandible into the centric relation in the same vertical dimension, and then the scan. And here's the final restoration with a very nice occlusion and very nice occlusion contact regarding the centric and the eccentric movements. And also confirmed with the occlusense, here we have a very nice articulation of the posterior teeth with enough or high bar of forces of the posterior teeth with minimum bar of forces of the anterior teeth, which is the needed mutually protected occlusion. So sometimes we are not in need for all of this hassle. Sometimes we have cases with maintained vertical dimension, no need to raise the vertical dimension. So we can scan the preoperative form of the teeth. Then you can remove the teeth that you are going to reduce, like in this case. And then you can scan the teeth again in the same vertical dimension with the same relationship. So no need in many cases to change the vertical dimension or centric relation. So scan before and then scan after locking the remaining structure. Now we have restored, or now we have recorded the same vertical dimension, and we can use this scan to record also the centric relation, but in the same vertical dimension with any kind of deprogrammers. So now moving to the most difficult scenario, which is how to record the interocclusal relationship for completely edentulous patient for implant prosthetics. Actually, the major problem regarding completely edentulous patient is the overclosure of the mandible in a more anterior position, which is called pseudoprognosism. So whatever your scanning protocol, whatever the kind and the shape of the scan body, whatever doing splinting or not, doing a scan device or not, doing reverse scan body or not, the major problem now is how to record not only the vertical relationship between the maxilla and the mandible, but also to record the ideal vertical relationship between this maxilla and this mandible. So sometimes we have established vertical dimension of occlusion with all temporary restoration or even with wax ramps. But the problem that this relationship is not in the ideal centric relation. So we have wrong centric relationship in these temporary restorations. We have an overclosure of side and open contact of the opposite side. So we have to fabricate a device to record this ideal vertical dimension, but in a more precise centric relation. So when we have wide interocclusive distance, like an FP1 and FP3, with fabrication of the bar, I can use the superstructure to fabricate this device. So I remove the teeth from the opposing arches, and then I place this pin to maintain the same vertical dimension of occlusion. This pin can be designed with mesh mixer and then incorporated in the lower part of the scanning device, and then bend the device and cement of the upper bar and the lower bar, and let the patient move to the anterior position and to the lateral position with occlusion spray in the upper part of the scan device. Now we have this very nice tracing. This movement is a protrusive movement, and then lateral movement, and the apex is a centric relation, which is the repeatable reference position. So we can record, or we can scan the upper bar alone, scan the lower bar, and then deprogram the patient movement, and then we can record this relationship in the ideal vertical dimension and centric relation. Now we have a very nice BMAs with very nice facial aesthetics and vertical dimension, and here's the final restoration with very nice occlusion. So the sequence again, when we have a proper established vertical dimension, we can use this restoration and this framework or superstructure to fabricate a device to record the ideal or the same vertical dimension but in centric relationship. Sometimes we haven't any reference to the vertical dimension or centric relation. So we can fabricate a temporary restoration with direct connection on these multi-unit abutments, and then I can place plate in the upper part and plate in the lower part, and then place this screw. This screw can be moved up and down according to the vertical dimension, and then tracing with the same technique, this device with direct connection over the multi-units. Here's the protrusive movement, lateral movement. The apex is a repeatable reference position, which is centric relation. Now we can record this relationship. And here's a face scan. Now we can move to the fascia-driven approach. Here's the sequence of the scanning sequence. And then we can use any software to, with the fascia-driven approach, place the Frankfurt Camber's plane midline and then place the teeth. Here's the fascia-driven approach. And now here's the final design. Look to the occlusion of the patient. Centric relation with the same position, which is repeatable without any interferences at the two opposing arches. Sometimes we have another technique that is very easier when we have ideal vertical dimension and good centric relation, like with temporary restoration with done during the guided surgery with stackable guide. So we have a very nice temporary restoration with very nice vertical and centric relationship. So we can do what we call reverse scan body. So we can realign the base of this temporary restoration, place a digital analog, and then scan the wall assembly with your scanner. Now we have made what we call the reverse scan body. So match this with the ideal vertical dimension in the temporary restoration. Now we have recorded the same vertical and the same centric relation, but also with what we call reverse scan body. And then you can complete your final design. And now moving to a very important step, which is Facebook transfer and mounting. And usually the question is, are we still need for these physical tools like Facebook transfer and then mounting on a semi-adjustable articulator, adjusting the angles and doing wax up or diagnostic wax up, and then doing or adjusting the condylar inclination and Bennett inclination? The answer is, in most of the cases, we are not in need for any physical tools. And according to literature, we have a lot of technique discussing how to make virtual Facebook transfer and how to make virtual mounting. And according to my publication in the GBD with my professor Dr. Ab Hamad and Dr. Islam Gad, which is completely digital approach to complete mouth rehabilitation, to depend on virtual Facebook transfer and virtual mounting. It's a very easy step is to scan the interocclusal relationship, and then we can make a large CBCT with large FOV extending from the maxilla, the base of the orbit, and the external auditory meatus. And then we can transform this DICOM file into an STL to be matched with the STL of the maxillary arch using Medit design software. And then we can do now the virtual Facebook transfer with determination of the anatomical landmark with mesh mixer or even Medit design software by placing two roots, one in the center of the meatus and 10 millimeter anterior to the meatus and 7 millimeter below the center of the meatus is the anatomical arbitrary hinge axis. It's still arbitrary but more close to the center of rotation of the maxilla of the mandible. And then we can place the Frankfurter plane, which is from the upper border of the meatus to the lower border of the borion, which is anatomical Frankfurter plane. Now we have done the virtual Facebook transfer, so we can place the hinge axis with the hinge axis of the articulator, the upper Frankfurt to with the upper border of the articulator. Now we have transferred the virtual Facebook, and also we have done the virtual mounting on a semi-adjustable articulator. Sometimes if you have your face scan, you can use this landmark on a facial landmark rather than anatomical bone landmark. So we can place also the borium point, the external auditory meatus, and then the progesterone point according to the facial or cutaneous landmark based on the facial landmark. And now we have placed the Frankfurter plane, so we can mount the hinge axis with the hinge axis and the upper border with the Frankfurter plane. Now we have transferred the virtual mounting, and we have done also mounting on a semi-adjustable articulator. So you can do your design based on the patient movement, her protrusive movement and lateral movement, and then you can proceed to the final restoration with very nice occlusion. And usually, most of the cases, I scan the protrusive and lateral movement with jaw motion or with my scanner to record the jaw motion in protrusive and lateral movement to make analysis of the interferences and also analysis of the patient border movement. So here's the lateral movement with very nice canine guided position. And also for the opposite side, here we can see that when the canine guided position, we haven't any interferences at the working or the non-working side. And also I like to confirm this interocclusal relationship with articulating paper. Here you can see the ideal occlusal relationship in static and also in eccentric movement with very nice articulation and very nice contact points. So here is the sequence after recording the vertical dimensions, interpolation, mounting, and here's the final restoration. And also I like to confirm this articulation with a digital method, which is occlusense. Here you can see that we have a high bar of forces of the posterior teeth and very low bar of forces of the anterior teeth, which is the mutually protected occlusion that we need to achieve. And also canine guided positions confirmed with occlusense. Here we have high bar of forces on the canine with complete disocclusion of the posterior teeth on the working and the non-working side, and the same for the opposite side. So thank you very much, and I was honored and it was my pleasure to be with you in such a webinar. I tried to discuss the main points of complete mouth rehabilitation regarding the interocclusal registration and how to enhance the trueness of your scanner by a very nice and very easy technique of recording vertical and centric relation of complete mouth rehabilitation cases. And I like to and I am looking forward to fruitful discussions through my Facebook account and Instagram account. So you can send me any question after you finish this webinar. And again, thank you and goodbye.
Okay, thank you for sharing all your tips with us, Dr. Mohammed.
Thank you very much, Jenny, and thank you for this chance to share more knowledge with Medit users and Medit Academy platform. Thank you very much.
Okay, so let's move on to Q&A sessions.
Okay.
Okay, so today we have 3 questions in total. So I'll start with the first one. Question number 1. What are the differences between recording CR bite in dentate and edentulous patients?
Yeah. Actually, the main problem, Jenny, for recording the centric relation and vertical dimension for a dentulous patient is the overclosure of the mandible, because the mandible closed in a very anterior position, which is called pseudoprognathysm. Okay, so the condyle now is not in a very stable musculoskeletal position regarding the articulated surfaces. So our rule when we are recording the relation of edentulous patients is to make a kind of device or something to record the relation in the anterior superior position of the condyle and in the vertical dimension. So we have to take care of the pseudoprognathysm or the overclosure or the more protrusion of the mandible in a more anterior position in completely edentulous patients. This is a very, very important thing to take care of during recording the centric relation of completely edentulous patients. And in the webinar, I discussed many techniques of how to record this relationship. Yeah, over implant for implant prosthetics and completely edentulous patient. Sometimes we can fabricate devices over the multi-unit. Sometimes we can fabricate devices over the bar to connect the multi-units. Sometimes we can depend on the patient temporary restorations to record this relationship. And this is very, very important question, by the way. So thank you for asking this question.
There are some ways to do the CR bite recording. So what's your favorite way in edentulous case?
Actually, I want to share with you some slides.
Oh, okay.
Actually, you have many techniques to record the centric relation. Okay, we have what we called bimanual manipulation of Peter Dawson with a special position to the patient and a semi-supine position to record this centric relation. The second one is Lucy jig. Lucy jig is very, very nice tool to record the vertical dimension and centric relation. And by the way, I fabricate Lucy jig with many of the cases with Medit design software. I can fabricate Lucy jig according to the needed height of vertical dimension to record the vertical dimension together with centric relation, or using anterior deprogrammer or leaf gauge, which is very, very easy tool, but have some limitations regarding the deep bite. And sometimes we have some sliding of the mandible during recording the bite with leaf gauge, or even overseating of the condyle in a more posterior position. And finally, the Gothic arch tracers that I discussed in the implant cases in my webinar, how to fabricate a very, very simple Gothic arch tracer with Medit design software. The main idea is to separate the anterior teeth with the level of the vertical dimension needed. Then you can deprogram the mandible into the anterior superior position by manual manipulation. And in the old days, we can inject bite restoration material. But nowadays, after deprogramming, you can scan this relationship with your scanner and no worries at all about the interdental space. Because according to evidence and according to literature, the more space between the teeth, the better trueness of the intraoral scanner. So no worries at all about the interocclusal distance that we are going to record and capture by the scanner.
Wow.
And that, yeah, I discussed many techniques also in the webinar. So this is just a short summary of how we are recording the centric relation.
Okay. Thank you for sharing your animation.
Thank you.
Uh-huh.
The webinar is full of animation.
Okay. Let's move on to question number 2. Okay, question number 2. There are some cases where there are teeth mobility. So how do you ensure that it's one's actual CO bite in teeth mobility case?
Yeah, this is also a very nice question. According to the mobility and according to the remaining teeth, we have different techniques. For example, for grade 1 and 2, almost there is no problem with recording the centric relation or vertical dimension. But for grade 3 and 4, this is a major problem. If all the teeth are grade 3 or 4, so I think we're going to scan this relationship to fabricate any device for vertical dimension for implant cases for planning. So in this situation, I like to fabricate a kind of a scanning device or a scanning tray to fix the teeth in place and then record the relationship. Another technique is to make a kind of palatal splinting for all of these teeth and then scan the relationship from the buccal surface. But If we have another remaining teeth with great mobility, one or two, we can scan the relationship from this side only, ignoring the other side. And sometimes I can use manual alignment rather than automatic alignment to align each tooth in its place. So I scan the most fixed teeth on both sides, then I can make manual alignment for all the remaining arch.
Mm. Is there any cases that you need to make stone model or working model to check the mobility?
Uh, Yeah, sometimes, but the same for the working model because the alginate material or the body elastomeric impression will push the teeth away from each position. So I think the best method is to scan the teeth, not to make models.
Mm,
Okay,
okay.
because the scanner will not push the teeth into another position, but the impression will. So it's
Mm,
much easier to fabricate scanning device to fix the tooth in place when recording this vertical dimension without moving the teeth away.
okay. Okay, the last one, we are left with question number three.
Okay.
Question number three. Are there any considerations to keep in mind when taking bite occlusion in digital way compared to the analog way?
Yeah, there is a lot, and I discussed many in the webinar also, but the first one actually is that the patient should not close in a very heavy forces because this will lead to a severe collusion of the cast, leading to an overclosure, which is a main problem. So the patients should close, and we should insist the patient, and we should train the patient to close in his normal bite without heavy forces with the masseter muscle, because this will lead to overclosure. This is the first one. The second very important one regarding the complete mouth rehabilitation cases. When we scan the relationship for complete mouth rehabilitation cases, we have to scan the relationship in two positions, right and left. Because if you scan in one arch, according to literature, there will be some tilting effect of the arch towards the acquisition side. So we have overclosure or collusion in one side, and the opposite side, we have open contact. So according to the recommendation of Medit company is to take two scans, one right and one left. Okay? But actually, according to my little experience, I think it's better to scan the relationship in one shot from right to the left, not taking two bites right or left, because this will decrease the tilting effect. And sometime also, in case that I'm afraid of overclusion or tilting effect, I can make manual alignment for the one shot relationship. This is the most important thing to do with full mouth rehabilitation cases, especially when you are raising the vertical dimension or when you have a very large interocclusal distance between the opposing teeth. So usually I consider manual alignment in these cases.
Mm,
Another important thing is that when you are recording the anterior teeth only, when you are scanning the anterior teeth only, you have to scan the four arch case. You cannot scan anterior teeth because there will be an over collusion or over tilting with the anterior teeth if you haven't posterior stoppers or if you did not scan the posterior teeth, because the scanner will not understand that we have only anterior teeth without posterior teeth, so there will be slight collusion or overclosure of the bite of the anterior teeth. So we have to take care of this point because I have many cases, especially when the start of using the scanner. I have many cases with very high restoration of the anterior teeth because I scanned only this sextant or from canine to the canine. So you have to scan full arch if you are going to restore only the anterior teeth.
I think this one was really a clinical tip.
Yeah. I have many also clinical tips in the webinar for each situation, for static rehabilitation cases, for Joe Motion software, how to use the Joe Motion software, and what are the main benefits of Joe Motion software. Also for implant prosthetics, for the single tooth and complete mouth, how to use the Joe Motion software to make sure that you have ideal occlusion or ideal occlusal contacts, especially for implant restorations.
I think occlusion is a key part to reduce chair time and everything, yeah?
Yeah, occlusion is very important thing, starting not only from the final prosthetics, starting from the diagnosis. So I placed a chart in the webinar of how we can make customize the scheme for complete mouth rehabilitations to reach to the ideal outcome, starting from the diagnosis and then moving to the analysis of the smile and then recording vertical dimension. And then I mentioned also in the webinar the different, or I think the easiest techniques to make virtual mounting and virtual Facebook transfer, and finally the design.
Mhm.
So each step is very, very important for ideal outcome regarding the occlusion contact.
Mhm. Okay, thank you for preparing such an informative webinar this time.
Thank you. Thank you very much, Jenny, and thank you again for invitation. And I'm looking forward to a fruitful discussion. I shared my two social media accounts.
Mhm.
If they want to send me any questions, I will be honored and I will be ready to answer all of these questions.
Okay, that's all about it for today. Please feel free to contact us anytime to Dr. Mohammed and to us as well
Yeah.
through meditedu@medit.com. Okay, it was
Thank
such
you.
a pleasure to have you here, Doctor.
Thank you. Thank you. It's my honor and my pleasure, Jenny, to be with you today.
Yeah, hope to see you next time. Bye.
Bye. Bye. Bye.